Hi, back with another session here. Here I'll take a case presentation. First, I will start with anemia in pregnancy. So, as we discussed yesterday, we have to start our case with the asking the patient identification details. So, first we'll ask for identification details, name, age, address, occupation, socioeconomic status, and followed by parity index. So first, how to introduce? First, you have to introduce examiner. Hi, I am Doctor This, and I'm here to present a case history of Vasantama, who is a resident of Neelamangala, 30 years old. She is occupation. She is housewife by occupation, and she is Hindu by religion. Belongs to upper lower class, and she is G3P2L2, come with 8 months of amenorrhea, and she is presenting here with complaints of easy fatigability since 2 months. So the identification details will be followed by the presenting complaints. So easy fatigability since 2 months, that you have to describe further in history of presenting complaints. So in history of presenting complaints, you have to say patient presents with 8 months of amenorrhea with easy fatigability since 2 months. Previously, the patient was able to do her household work, but for the past 2 months, she get tired even with minimal work. On walking about 50 meter, patient complains of fatigability, giddiness, blurring of vision, which is relieved on rest. So, in presenting complaints, you have to first describe the chief complaint, followed by you have to elaborate the negative history, whatever you will ask the patient according to the case. Like here, I'll ask her about the history of any bleeding during menses prior to pregnancy. This will rule out a menorrhagia. So there is no history of increased bleeding during menses prior to pregnancy. No history of exertional dyspnea, palpitations, PND, pedal edema, or giddiness. We have to rule out heart problem also, because her main complaint here is easy fatigability. So that's why no history of bleeding or leaking PV, no history of bleeding PR or melena, no history of passing worms in stool, no history of fever with chills and burning micturition, ruling out UTI, no history of cough with expectoration, hemoptysis, evening rise of temperature, or contact with a known case of tuberculosis, no history of any drug intake, no history of any yellowish discoloration of skin and sclera, not a known diabetic and hypertensive. So that you have to take first this identification details, followed by parity index, then chief complaints, and then history of presenting complaints. After history of presenting complaints, you have to ask patient, you have to actually be in a sequence. So you have to first present your history of present pregnancy trimester wise. In the first trimester, there is no history of nausea, vomiting, weakness, no urinary symptoms, no drug intake, and no history of craving for abnormal food, that is pica, which is associated with the iron deficiency. In second trimester, quickening in fifth month, first ANC visit in 20 weeks, given TT and iron folic acid that she consumed. That you have to mention, because if she is not consuming the tablets, or she is non-compliant, non-compliance for that iron tablets, then what else she took, any FCM injections or anything, that you have to mention here. No, so her first ANC visit was not in a first trimester. Here it is in the second trimester at 20 weeks. So probably she didn't took that folic acid tablets. In the third trimester, fetal movements present. She is perceiving that well. No leak or bleed PV. No history of pain abdomen. No history of using any contraceptive methods. Menstrual history. Age of menarche is the 13 years. Her previous past cycles were regular, with no pain and passing on any passage of clots. Or you can also describe how many pads she is changing per day. Followed by the, you have to ask after menstrual history, you have to ask this ops history. In ops history, she is married for 13 years, non-consanguineous marriage, and she is G3P2L2, like two living children, both delivered by normal vaginal delivery in a government hospital. and post delivery no complications were noted. Her postpartum period was uneventful, like that you have to say, followed by the family history. There is no history of any congenital anomalies or twinning or diabetes, hypertension, no history of any tuberculosis, epilepsy, asthma, no history suggestive of any cardiac ailment, no history of previous surgeries, blood transfusion. In her personal history, she is taking mixed diet, having a good appetite, sound sleep, and with regular bladder and bowel habits. On dietary history, she is consuming 2100 kilocalorie per day with a deficit of 300 kilocalories per day. That is like if you have taken this, then it's okay, you can say. Otherwise, you can ignore diet history also. On general physical examination, here is a pregnant lady, 30-year-old, moderately built and nourished, conscious, alert, and cooperative, with a pulse rate of 84 beats per minute, regular and good volume. On her BP is 110 by 68 mm of Hg. Respiratory rate is 14 per minute, regular. She is afebrile on touch. Presents with pallor, but there is no. But icterus cyanosis clubbing edema lymphadenopathy is not there. On examination, thyroid, breast, and spine are normal. Her height is 146 centimeter, weight is 56 kg, BMI is 26.27. So do not miss to learn the BMI and the criteria like overweight, obese, underweight, and normal. What is the range you should know. On systemic examination, on cardiovascular system examination, S1, S2 heard, no murmurs. On respiratory system, normal vesicular breath sounds heard, no basal crabs, no abnormality detected on CNS examination. Then you have to come to like PA, you can say normal bowel sounds heard, otherwise you can leave that. Obstetric examination, this is important that you should know and you must know if you are taking any HOPS history. So on inspection, we are taking 3 points: inspection, palpation, and then auscultation. So on inspection, abdomen is uniformly distended, globular in shape, umbilicus everted, hernial orifice is normal, flanks do not appear to be full, striae gravidarum and linea nigra is present, no scars over the abdomen. On palpation, the circumference of abdomen is 76 centimeter. Her symphysiofundal height is 28 centimeter, which is corresponding to the 32 weeks. On fundal grip, we felt soft, broad, and non-ballotable, suggestive of breech. Lateral grip, knob-like structures on the right side, suggestive of limb birds. Uniform resistance on the left side, suggestive of spine. On the first pelvic grip, the smooth, hard, ballotable mass, suggestive of the head. Second pelvic grip, fingers converge, head do not engaged. Uterus is relaxed. Okay, so fetal age and weight, you can this is an estimated thing. You can avoid this saying this. Auscultation, fetal heart sounds heard along the left spino-umbilical line, which is regular, 142 per minute, and rhythmic. Then on diagnosis, she is a 30-year-old G3P2L2 with 32 weeks of gestation, moderate anemia, probably due to iron deficiency, not in labor with no clinical signs of failure. Like that, you can say. Okay, thank you.